Taking the stage is LaFond, Director of the Center for Health Information, Monitoring, and Evaluation at John Snow.
Hello, everyone, and thank you to Cheryl Heller and her team at the School for Visual Arts for inviting me to be part of this program. I'm really honored to be here with all the other speakers, and I have to say I feel like I'm among the few and the proud measurement people that are actually in a sea of design people. So I feel a bit overwhelmed, but very honored. I work in global public health at John Snow. We provide research and technical support to improving health for people in low-income settings in the US and abroad. My team in our Center for Health Information Monitoring and Evaluation was introduced to the idea of human-centered design about 3 or 4 years ago in the context of an initiative called Innovations for Maternal, Newborn, and Child Health. It was funded by the Bill and Melinda Gates Foundation under a grant to an international NGO called Concern Worldwide. So JSI, my team, was engaged as the research partner for the second phase of the project from about 2012 to 2016. This multi-year effort was aimed to overcome barriers to improving access, effectiveness, use of essential maternal, newborn, and child health services among women and children in poor communities in Africa. The project itself was framed by the concept of innovation, which is a term that is bandied about in global health circles with various definitions and concepts and meaning. Over the course of the lifetime, the project introduced innovation in 3 ways. One was in the identification of health interventions that were to be tested, new ideas or adapted older ideas for improving health outcomes, quality of care, health worker motivation. The goal was to find new and fresh approaches to be scaled. A second innovation was in a decision to use human-centered design in each of these 4 pilot projects at the early stages of project implementation, which is really, it's quite a new approach in global health circles. People are using it more frequently, but there's still a fair amount of misunderstanding or misconception about what it's about. So it was seen to be very thoughtful and innovative to use human-centered design as part of the program strategy. And the third innovation that they used was to introduce a more iterative and learning approach to data collection and program implementation. And I'll explain how the research and monitoring and evaluation that we did helped them achieve this goal. So we were tasked with coming up with a research strategy that met a lot of objectives. We had to provide evidence of effectiveness, so impact. We've been talking about impact here. Public health programs, by standards, are looking at impact all the time. We're measuring, using theories of change, and we're measuring program outcomes and impact as part of our work. And there's a strong, long discipline of impact measurement in the public health sector for years. So we had to answer the question, did these interventions work? Were they successful in achieving their outcomes? The second thing we had to do was capture that learning that emerges during implementation, not just waiting to the end to say, well, did it work? But to say, what are we learning along the way? Are our theories of change actually coming to fruition? And what do we use this data for? If things are going well, can we adapt the intervention effectively if they're not going well? So we collected data along the way to allow the program to be iterative. The third thing that we did was really focused on what role did human-centered design play in this context? How was design applied? What was learned in the process of using design? And we faced 2 big challenges in this context from the vantage point of being more traditional public health evaluators. One was this idea of combining a more impact evaluation, standard way of measuring impact, with a more iterative use of data. So changing the program with data as you go along is the antithesis of doing like a randomized control trial or an impact evaluation, because you're messing with the design, right? But the implementers wanted to do both. So we had to develop a hybrid evaluation strategy that allowed them to do that. We also had to focus in on how do you actually measure the influence of human-centered design. And we used a case study approach for that. And what I mean is a case study as a research methodology with a standard protocol used systematically across the 4 cases. It wasn't an evaluation of human-centered design because we couldn't manage a counterfactual to try and measure the effectiveness of design in some settings and not others. But it was to allow us to go deeply into the experience of each of these 4 programs and how they use design. So I'm focusing today on this aspect of our work, how we approached and assessed the added value of design in the social sector. But I mentioned the other evaluation strategies because they were part of the context of our research overall, and to show where there is strong integration between trying to understand how design works and how that can be integrated into wider evaluation strategies in public health. So first of all, we started to try and understand what design was and what kind of lens it brings to the table. We searched the literature for studies of the effect of design, and we found almost nothing. We therefore had to go to designers to help us frame the study of human-centered design in practice. And we posed the question to them, how do you determine whether human-centered design has been effective? And the answers were like very vague and kind of like, I don't know, I didn't stick around long enough to see. And a couple people said, well, it's just magic, you know, right? Then we said, okay, as evaluators, magic isn't going to work, so we have to think about something different. So we asked, how do you describe design and its pathway to success? Because we're always looking at pathways in evaluation. And we were given this diagram. And we said, okay, how are we going to measure that, right? And of course, you know, the impact is somewhere off on the other end of the slide. It stops with design. So we said, okay, imagine from the perspective of traditional evaluators measuring outcomes in terms of quality of care, uptake, and family planning, and the role of design in that process. You know, we needed more grounding, not necessarily in numbers and objective measures only, but at least in the concepts of that would help us understand what the pathway from the use of design is to the health sector outcomes. So in this project of the Innovations for Maternal, Newborn, and Child Health, we decided to come up with our own metrics of how to document and assess the influence of design. We asked these 3 questions. How was design applied in these settings, these 4 settings? What was learned from that process, and how was it applied to the intervention? And then how did it influence the intervention over time? And we mapped out a series of metrics at the bottom of this slide that are helping us explain and document and demonstrate the influence of design. The first was the development of empathy, which I'm sure will ring true to all of you. But it's something that in the public health circles, people kind of shake their heads and say, oh my goodness, we're public health people. Of course we have empathy. We wouldn't be in this business if we didn't. So actually trying to pin down what design brings in the concept of this tangible empathy and what it's used for was something we wanted to capture. We also had to try and look at when you learn from empathy and you apply it to a program design, what happens? What is that magic? And we captured that magic in this idea of fit, in that the fit of the design is the design, the fit is to the needs and the insights and the expressed ambitions of your end user that you've captured in the design process. So you're making your program very closely fit with your end users by involving them in the design process and gaining insights from their work. That, in and of itself, should lead to better uptake, because if it fits, people will be more likely to pick up a behavior or use a tool. And going on with kind of typical outcome measures that we use in public health programs, because we want to look at sustained change. We don't just want people to run with the idea for a couple days. We want them to incorporate it into their normative behavior. So we use these ideas of buying in and ownership of the behavior change that was trying to be achieved. And of course, we wanted to look at the link to outcome, but without a really standard impact evaluation of design, we were just looking at some evidence where outcome was achieved. Oops, wrong way. We used the case study method, as I said. It's mixed methods. We relied on the evaluation design from the whole project. So we used the rigorous impact evaluation that my team was doing. We used the deep dives looking at the processes that we were doing. And we had specific interviews during the design process and interviews with the people that were involved in program implementation and the design process to get their reflections on how that process went and to look backwards at the end to say, from your experience as a public health practitioner, how was using design in this context differed from using traditional program implementation and planning strategies? So we were able to study this idea of human-centered design in 4 settings. Design was applied differently in all 4 projects. In 2 cases, there were professional design firms that were involved with the project. In one case, the team took guidelines like IDEO toolkits and others and created their own design process. And in the last case, there was a workshop for the team of implementers, and they were introduced to the principles of design and then let go forth and see if you want to apply it or not. That's fine with us. I'm going to talk today about one of the activities, which was the development of a mobile phone application to try and improve health worker motivation, where design was applied in the early part of the project to help design the mobile application and to influence the program. That project was implemented by Concern Worldwide and Grameen Foundation in Ghana, and Think Place was the designer involved. So we addressed those 3 questions in the research. How was design applied? We documented really for the public health community to see how design was applied in these studies, how the workshops took place, the different research that was done, the storytelling. We're able through this research to try and actually illustrate some of the work of designers and how they are helping people make sense of public health problems and solutions. So each of these aspects of the design went into the mobile phone application design and as it was being implemented, and were used in the end to create a better outcome. And I can say that with confidence for this piece of work because we found that in our research and our impact evaluation that uptake was very high amongst community health nurses in using this phone application. And in the qualitative analysis that we did, we found several instances of evidence that the phone itself and the use of the phone was addressing a lot of the frustrations and the barriers that emerged from the design research to try and pinpoint some of these areas where the work was being more frustrating to them, where they weren't getting support from their communities and their supervisors, where they were unable to actually access information. And with the phones, they were able to get information and answer questions when they were out in the field. So we found quite a bit of evidence that the learning from the design was very instrumental in actually creating a good fit with what the nurses wanted, and the uptake was good. So in that context, we found that design had been very influential. But we also had to step back and say, well, design wasn't the only intervention that was used. There was a whole other program strategy around it. So design was one aspect of it that actually helped it shape the intervention and make it effective. But I don't want to go into the outcomes right now. What I want to talk about is what we learned about measurement, because it was a real experiment, and it was a way of building our knowledge and our understanding about what is design supposed to do and how can we measure it more effectively. And from our 4 cases, we developed this grounded theory of how design influences public health outcomes, or could influence public health outcomes. And we welcome all sorts of feedback and discussion on it, because it really is 4 cases of experience that we've used, and we'd like to try and see whether this fits in other contexts, in other programs in public health, and other social sector areas. You can see the pathway here shows that the link between empathy, the fit, the uptake, and the link between buy-in, ownership, and outcome. But there's also a second pathway along the bottom, which is one that we didn't really explore in our design of the research, but came out very strongly, which was how the design process influenced the implementers and their whole approach to the work that they did. They were very interested in doing an iterative approach after they were introduced to the design process. This was not something that normally is done in public health programs. There's a lot of commitment to the original design and moving through, not so much about iteration and learning with the end users. And the teams in each of the 4 projects that were exposed to design actually were very, very passionate about the idea of going back to the end users. So the design of the project was influenced, but so was the behavior of the people implementing the project through the introduction of human-centered design. So from an evaluator's standpoint, human-centered design is a slippery concept for us. It needs to be studied, it needs to be documented and assessed, and we need to do that to improve people's understanding of it, both of its value and the way to practice it well in these different settings. What we found enriches understanding, but there's so much more to explore. And in fact, our projects used a very small dose of design, and there were 2 more intensive doses, but some of them were very light touch design. So we really need opportunities to explore deeply how design is applied and what its influence could be in a full-fledged kind of intervention. There are many missed opportunities for using design in the projects that we looked at. Some of the information just didn't go anywhere. People didn't pick it up. I feel like a lot of the learning from design wasn't fully exploited in some cases. And in fact, the designers came in after the project was designed. A couple of speakers mentioned that there wasn't this opportunity to identify what the problem was and the solution with the users from the very beginning, but to retrofit design into an already designed kind of project. And that's a missed opportunity as well. In terms of measurement, I think that the metrics of how design influences both the process and the outcomes of social sector programming is absolutely essential. We shouldn't miss that. Impact is important. There's a lot of emphasis on impact methods, and we can feed into that discipline and try to understand where design influences impact. But we also need to look at where design has a very powerful driving force in the process of change. And I would encourage people to look at both impact and process metrics to try and understand the influence of design. I think design sits nicely and sweetly in where global health is going these days, because there's less of an emphasis on just looking at outcomes at the end and a lot more emphasis on learning while implementing. And design is about bringing data and insights into the learning process. And the evaluation strategies for learning that are being tested now in global health blend very well with design techniques, and I think there's opportunities there. I think we should look for opportunities to embed researchers and evaluators in teams of designers so that we can work more closely together on this measurement challenge. And I think that through evaluation and through discussing the impact of design, we can actually build a very strong case for where it fits into social sector programming and where it doesn't fit. And that's also a very important message for us to give. Thank you.